Okay. So they asked me to go ahead and do the anatomy very quickly over again. This is my daughter Erica, by the way. Say hi to everybody. She lives out here. It's the only thing I hate about her. Not fair. Okay, very quickly. Do we have her up on the screen? There she is. Beautiful. Great. Yes, you are. Okay. 12. No. She's 29, but she'll always be 12 in my head. The only picture I have of my kids in my office, they're 7 and 4. I still think that's what they are. So I'll stroke her head, and she hates that, but I'll do it anyways. Okay, so here we go. Forehead. I said, remember what our palpable marks are. So I'm going to go through this very quickly. Here we go. That's temporal crest. I can feel it on her both sides, okay? Frontalis muscle from temporal crest to temporal crest in 98% of individuals. 2% will have some muscle that goes into the temple. Those are the ones that will spock on you because you don't get lateral enough with your injections when you're doing your frontal injections with toxin. So, supraorbital artery comes out, open your eyes, please. Supraorbital artery comes out from the medial iris right over here. I put a little nick over there. She has an orbital notch. You take after your mother. I don't have one. And then, what does she ever take after her mother, by the way? And then, the artery comes out and goes north. Remember I showed you that, right? Supratrochlear, can you frown? Good girl. I think you're due for your toxin. Okay. That's where the supratrochlear is in most cases, or it might be a little bit more towards the artery, the other artery over here. And that's doing this as well. Okay? We got it? Super. 1.5 centimeters. Remember I told you 1.5 centimeters from the orbital rim. So right from here. The artery is running what? Superficial, deep. Could be anything. It's running from deep to superficial to get up onto the surface over here. This to me is a no-fly zone. No-fly zone with a major needle with any type of product. If you're very good injector like Kent is and you want to go down in between these areas and put a little product on bone over there with a BD2, that's reasonable. If you want to be a little bit more like me who's chicken, my approach is lateral from the side over here with a cannula, and as I come across, if I hit something or I don't hit something, I'm through it. Idea is be careful over here because you might blind the patient. Then we have one thing. Can we bring the camera in just a bit? We'll focus just on the upper half. That's great. Thank you so much. We have one thing that stays on the bone, I told you, and that's the deep branch of the supraorbital nerve. I call it the Rhonda nerve. Rhonda is her mother's name, my wife. It's because it goes where it wants to go and everything else goes the other way. So this nerve over here stays on the bone. All the other nerves come up superficial. This nerve stays on the bone to get to the back over here to supply her head. It has a little artery that runs with it. And I know that it's about 1 centimeter to 1.5 centimeters inside the medial to the fusion line, so I don't go here with a needle. If you go down to the bone over there with a needle, you run the risk of touching that nerve, causing pain. You pain them, you won't retain them. All the other areas over here, I'm putting a D for what? Deep. Go down onto bone. The worst that happens is you go through the artery. When you remove your needle from the artery, you put pressure and you tamponade at it. The galea, which is that thick fascia underneath the muscle, is going to protect those vessels when you inject deep. And it's going to spread the product for you. Do I want a product that spreads or a product that projects out like a unicorn over here? Spreader. So I'm going to blend something 50-50 to get it to really spread. I'm going to use something that has a low G prime. Okay? I'll use that word. Great. Any questions? Deep, 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 deep. I don't care where you go. Even if you're going right through here, deep, you're going to be behind the vessel. You won't be in it. So it's deep, 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 deep. Don't go over here because, be careful over here because you might blind the patient. Be careful over here because you might hurt them. Okay? That's forehead. To me, it's simpler than injecting here, which is much more dangerous. We're going to talk about temple now. Temple. 1 centimeter up, 1 centimeter over, following the lateral orbital rim. This is her sweet spot for temples. Do we ever do your temples, sweetie? I don't think so. No, I don't think so. Okay. So, 1 centimeter up, 1 centimeter lateral. There are vessels coming all over the place. There is a plexus of veins over here. If you want to be very careful, you have the patient bend their head forward for a minute or two. They'll engorge. You put them back up. Then you can mark them out and try to miss them. There is an artery that comes across over here, which is the frontal ramus branch of the superficial temporal artery. It's probably somewhere there on her. Yeah, there's her pulse. Okay? That's a tortuous artery that's going to join with the supratrochlear. You don't want to inject into that either. But it's more posterior. And there's deep vessels coming from the internal maxillary and the pterygoid palatine fossa over here. There's deep vessels over here too. But those deep vessels, as they're going from here to here, they're getting smaller and smaller, and they're the size of hairs when you're up over here, so the chance of you putting something in them is absolutely remote. So when I inject, anytime I inject down onto bone, it's a vertical pass. It's completely perpendicular to the skin if I'm going down to bone. If you go at an angle like this and you're using cannula, it's fine. But if you're going with a needle, you're going to cut across a lot of things. Take the shortest distance right down to bone. I start the injection. I put my finger behind to prevent the product from running into the hair because it will go all the way to the back over there. You'll waste product. This is economy of product. And the product will start to spread like you dropped a pebble into water, into a pond. It will stop here because it's fused. It will stop here because it's fused. Your finger will feel the product pushing against it. You don't let it go. There's only one place that it can go. It'll fill the whole fossa. And it does it by creating its own tent pole and canopy. You just deliver the product to that area and it does everything for you. It's fantastic. It's marrying the anatomy, the science of the product to the anatomy of the region. I love to do that because I am a lazy injector. Like Kent, you watched when he was injecting, he puts his needle down, he gets it to where he wants it to go, he doesn't move the needle. He believes in the science of the product to do what it's supposed to do. I believe in the science of the product that I choose over here. So, let's talk quickly about that. People ask me about this at the break. If I have a very shallow temple, but it's a very wide, shallow temple that I want to fill, am I going to use a product that's going to stick up like a stick or something that's going to be a little more spreading? If it's a very deep temple, in males that you see sometimes, that's only from here to here, but it's a real crevice. Do I want to use a tent pole or something that's going to spread? That's all you got to think. Do I want it to spread? Do I want it to lift? How soft do I want the product? Remember face maps, the skin quality. She's young. She has good skin quality. I can get away with any product. But if she was much more mature, she was in her 60s or 70s, and her skin was very thin, I don't want to see a tent pole under there. I'm going with a softer product. One up, one over for the temple. If after I inject her, I pull up my needle, typical volumes is 0.2 to 0.4, 0.5 for me. Of blended product, 1 to 2. I'll use Voluma. I'll use Resti-Lift. I'll use Bellotero. I make a sort of an inventory of what I want to do on the whole face, and I say, well, listen, I got to do, let me think now. I'm going to have to do a little chin or a little cheek, and I want to do this, so maybe I'll use Voluma over there. I got to do something that spreads over here. That's great for Resti-Silk. I'll use it there, maybe the Resti-Silk on the tear troughs. I kind of make an inventory of what I want to do, and then I get an idea. Okay, I'm going to use 2 syringes or 3. 2. She says she has budget for 1. Up goes the price by $200. Can you afford it? Yeah, I can. Now she gets her 2 syringes, same amount of time, and gets the result. Okay. If she still has a defect over here, even though I filled over here, I have 1 of 2 choices. I go back into the spot. This is the sweet spot. Stay there. I go back into that spot and wait for the product to get down there, which it will. Or I can go with a cannula and go ahead and attack that area. Do not put a needle under the skin in this area over here above the zygoma because it is full of those big vessels that I was telling you about. There's a transverse vessel vein over here we call the zygomatic vein. Or you don't want to touch that thing because you can cause problems with venous obstruction as well as you can with arterial. Okay? We're good? 1 up, 1 over. Now we're going to do the lower face even quicker and it's easier. Lower face. Mom's going to love me for leaving these marks. Here we go. External carotid gives off a branch called the facial artery. Facial artery darts underneath the jawline over here. Okay? It darts under the jawline. Clench your teeth from here. That's the girl. Here's the anterior border of her masseter. This is the area that we love to feel. That's the anterior border of her masseter. About 1 centimeter in front, I have her pulse. That's where the facial artery comes over the bone. I told you it stays deep, and it does this. Drives like her mother drives. I'm only kidding. She in here? I'm going to really get it. It's very tortuous. It's very tortuous because open your mouth all the way. That's why. It's got to act like a spring. Whereas The vein, on the other hand, does a straight path like this, and it's found inside the masseter. When we do microsurgery, we have to plug into the artery and vein separately. They're not running together as they normally do. I don't know whether the vein is going this way or this way, whether the artery made a right turn here instead of a left turn. To be honest with you, I don't care. What I care about is how deep is it, the depth. You feel for the bottom. I told you, this is the other area. You feel for the bottom of the maxilla. There's nothing here. Here's the bottom of the maxilla. In this entire area over here, those vessels are running deep. They're running on the buccinator, like I told you. They're running underneath zygomaticus major, underneath zygomaticus minor, or over zygomaticus minor in this area, but I don't care because it's in the upper zone here. I'm talking about this area. I pinch the skin to distract, and I fire in with a needle or cannula. My preference is cannula. Got it? Great. So this is one up, one over. This is superficial. And as Kent was showing, and what I do as well, is we both like to put our cannulas in from here, because when you push the cannula forward, you're walking away from danger. You push the cannula backwards, you're walking away from danger. If I start from over here and go this way, it might be easier for me to do that because I'm right-handed or whatever. I have the risk of going down deep and catching that artery. But if I'm standing over trouble and then I walk away from it, I'll never get into that artery. Okay? Beautiful. Now we're going to talk about what I call Caucasian country. Outside of the iris, that's the other soft tissue landmark. Outside of the iris, coming across into this area over here, we call the zygomaticotemporal or zygomaticomalar region. I told you the artery that comes out over there is the transverse facial artery. Out of the parotid, it comes as the emerging artery. And then it does this. It arborizes here. It goes deep over here. I don't care because I'm going superficial. But it arborizes over here. This thing is pretty dry. Let's see if the pink one works better. A little bit. So my risk over here is bruising. I can inject superficial or deep, whichever you like. I personally prefer to put things on bone when I can because I know it stays there. This area over here is the gliding plane. There's about 23 different fat compartments in the face, but you don't have to know them. I don't even know them. I have to know them when I'm doing a facelift, but I don't have to know them when I'm putting a needle in. I just have to know the depth. So to me, there's only two that I have to worry about. The superficial ones and the deep ones. The deep ones are attached to bone and they're there to allow the muscles to glide. If you take a look at the SUF, the suborbicularis oculi fat, it is stuck to bone because it's acting as a glide plane for the muscles here. If you put product in there, it will stay there. It's not going anywhere. If I put product into the superficial fat pad, which is the mobile fat pad, when she smiles, she's going to drive that product up and it's going to start to do this and make a shelf in her face. So I prefer to go deep when I can. These are the patients that you inject superficially when they're more mature in their 60s or 70s and they come back and they say the product moved. It's down here. It hasn't moved. It's just dropped from the weight of it. Right? But if you put it into the SUF, it stays there. We dissect it out. We see it's right where you put it. Okay, so this is superficial or deep. S or D. Now we're going to head into Asian country. Because Asians, for the most part, have anteromedial flatness to their cheeks. And this is the area that they love to inject. Right here. Love to get more projection over there. Problem is, we have that infraorbital artery, which if you line it up with the inside of the iris, about 5 to 8 millimeters below it, is sitting right about here. I'll mark it in black because my red is dyed. There it is. When I want to do an infraorbital nerve block, I put my finger over, it's actually a little more medial, I put my finger over the tear trough, and where the cross-section is of my nail, right down there is where I'm going to find the infraorbital artery, and I can find that foramen almost all the time and put a little drop of anesthetic in there and give a V2 block. I don't want to do that with filler, right? So we have that 5 to 8 millimeter border over here, which we can put product in for our crescents, for our tear trough, nasojugal groove, as Kent and I call it, and then the lateral orbital crescent or tear trough extension that goes this way. Here I can go on bone because I'm under the orbicularis muscle. There's SUF over there. Here the orbicularis muscle is stuck down to bone, right up to the medial iris. So I have to put very little product down on periosteum with cannula or needle, very little, and I coat over the top subdermally. We'll see that. But this area, I don't know where that vessel is. It's coming out and it's doing all types of crazy things. It wants to supply everything. So I'm putting a big C over here, which you might call caution, but I call cannula. I just won't go there with a cannula. And I see so many excellent injectors do that. It makes my heart shudder. They're good injectors. It's just a numbers game. Eventually, do this every day in your office like the Asians are doing, and you're going to catch it. Do not go from this angle over here because of that little hood. You're going to catch it and go in there. Come in from the side or from this angle over here, you won't. We have everything covered except the piriform area. The piriform area over here is very interesting. We love to inject there. Kent was showing you why he loves to inject. It's also for external nasal valve situations. It's also to project the patient. It's to lift up the tip of the nose. It's to narrow the nostrils. Maybe we'll narrow some nostrils today. It's a lot of fun. I love to inject over there. There's a problem though. And the problem is that this facial artery that's going back and forth like crazy like this will cross into the piriform region in 4%, so 1 in every 20 or 1 in every 25 Caucasians will have the artery sitting in that area. It's 17% or 1 in every 5 to 6 Asians. Why? Because Asians are genetically flatter over there and the artery doesn't have to climb over during evolution or during genetics or embryology. The artery doesn't have to climb over any bone. It just has to go there. But the artery is lazy, and so in Caucasians where we're built up with bone there, it stays to the outside of the nasolabial fold. That's why the Asians are at a disadvantage, because that artery is sitting there 1 in every 5. So when I put product in over here, I have only one thought in my mind. I must put product where the artery is not. And there's only 2 places that the artery can't be. It's not in the skin, so I'm safe if I put it intradermally. And it's not on the bone, because it's worked its way from deep to superficial here. It's somewhere in between. When we do our osteotomies for rhinoplasties, we're going right on the bone over there because it's beneath the artery. I might go through it, but I won't be in it. And my direction of injection is aiming at the opposite commissure, like this. I want to stay away from that angular artery, which is the continuation in many cases, but sometimes it's not. Sometimes that facial artery just ends as an alar artery like this. So my injection is like this. Hugging the ala, aiming down and away towards the opposite lip, and I must feel bone before I inject. If you don't feel bone for whatever reason, do not press on that plunger. This is the number 1 place for causing visual problems. And we inject there every day. Okay? So here it's skin or bone. And that's it, guys. That is injection anatomy. We can talk about lips afterwards. It's a separate area. But that is injection anatomy for the face. Deep, 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 deep. Don't go under the skin here. Be careful when you go under the skin here because you might blind the patient. Here you might hurt the patient. 1 up, 1 over. Superficial or deep, cannula on bone or skin. Finished. Keep that in mind when you're injecting, and you will stay safer. Is that fair enough? Great. So, anybody who wants to take a picture of this, she'll circulate around and you can shoot it. But otherwise, we're going to have it in your thing. And what I've done over here, I try to do in the animations in the PowerPoint that you guys will be able to flip through, and it will remind you maybe of the crazy guy who was jumping around on stage talking about this, okay? Can we get to inject some patients now? What do you think? Any questions at all? Fire. Yeah, nice and loud so I don't have to repeat it.
Any use for nitroglycerin at the time?
Yeah, I told you that in probably 18 out of the 23 cases that were reviewed, it was all cannulas in the glabella. Thanks, mate. It was all cannula use because they were going this way. I see people who are injecting forwards with cannula. By the way, we can do it either way. There is no right, there is no wrong. There's safer and not so safe. Okay? There's not safest. What Kent and I are trying to do here is not change the way that you inject. God forbid, don't do that. You heard him mention at the beginning that you should learn how to use needles and cannula, and I agree 1,000%. If you want to be a good injector, you have to learn how to use both. And the learning curve is very quick with cannulas. But you have to learn how to use both. If every time I sat down to have a meal, all I had was a fork, I'm going to miss out on some great soups. We have the instruments. Learn how to use them. Start off in easier areas. Kent is going to show, he's going to talk about his technique. A cheek is an area that's a little more forgiving than if you're going into a tear trough. Start off, once you get the feel of it, and I'll try to verbalize everything that I do. If I start doing things a little differently than he will, he'll tell me this is the way he does it. I'll do it his way to show you that there are more than one way to skin a cat. How many ways to make change for $1?
Yeah, well, it depends on who you're talking to, but there's about 100 ways to make change for $1.
Yeah. 293 for the American dollar, but now I understand.
We don't have any cents.
Yeah, we don't have any cents now. That's correct. So learn to use both. There's some areas that you're just safer with some than with the others, and if you understand what you're trying to create, you'll say, wow, I think I'll use a cannula here.
We hate to be boring, but a lot of times we end up finding we inject almost the same way.
But that's how we kind of met. I said, the other half of my brain is sitting on the other side of Canada because, we first met and I said, I called him up and I said, I have to ask you a question. And it's almost as if he's reading my mind. He says, you're injecting differently, aren't you? I said, yeah, I find that I'm pushing product instead of pulling. Remember we had this discussion maybe 10, 12 years ago. He said, I'm pushing it too. So we evolved along the same lines. Is it the right way or wrong way? I don't know. It's just experience that told us this is the way to do it. So it's kind of interesting. What are we going to do? We have a question over here. I'm sorry.
How far apart are your injection points on the forehead?
We're going to show that, but I usually stay about 1 centimeter. Depending on the product that I'm using, it's about 1 centimeter apart. You can get a little bit of undulation, and then you can fill in the gaps if you want, but it's usually a 5 or 6 point individual down on bone with needle. You can do it with cannula. Absolutely. I've done it both ways.
Cannula.
Yeah. And the interesting thing is maybe we'll do this on a patient. I can show you the difference. Cannula is safe, but I want the cannula to come in from the side. Mm-hmm. The question that was before was there any problems in this area? Yeah, if you go vertically down like this, you're going in the direction possibly of the artery, and if you do catch it, cannulas take the path of least resistance. It won't come out, and you'll keep flooding the artery with product. That's when you get into trouble. So I want you to think, well, now the artery's going this way. I got to come across sideways. That was the answer to your question that it took me about an hour to come up with. Sorry. But that's what you do. What's the difference? There's a little slight difference with cannula than there is with needle. Needle, I know I'm on bone because I'm touching the bone and I feel the needle. And in fact, I load them onto the BD tube because of the fact that after 3 or 4 injections, needle's dull and I got to get rid of it.
Right.
And if you do that with a regular syringe that has a hub, you keep losing the product in the hub. Unless you have the fancy syringes.
Dose savers.
The dose savers that Kent has. Right?
Yeah.
So you got to take off your needle or you got to pitch the needle after about 3 or 4 injections because you're actually touching the bone and it dulls. With a cannula, I'm not sure that you're on bone. If you use a 27 or a 30 gauge, maybe you can perforate the galea. But the galea, I got to tell you, is like this. It's thick like hell. And if you try to perforate it with a 25 gauge cannula, you're really going to have to screw it in. It's very hard.
Can't do a 25.
Right. So what ends up happening is the cannula runs above the galea but behind the muscle. It's still a safe zone because the vessels are on the surface, I told you. So it's still a safe zone. What's the problem? The problem is the products that we have lidocaine in them. And if I do half a forehead with a cannula and I do the other half with a needle and I ask the patient to elevate their eyebrows, they can't lift their eyebrow on the side that I used the cannula because the lidocaine got into the muscle and softened the muscle movement. And for me, it's all about the experience. I want my patients to leave the office and go meet their friends. Right away. That's when they look the best. I don't want them to be paralyzed that they have to go home for half an hour and hide. Because chances are, their friend will say to them, you look fantastic, you look great. And maybe, if I'm lucky, they'll say, I just came from Swift. What are you talking about? When I get my injections, I have to go home and wait for an hour for everything to start moving again. That'll bring you patients too. The experience. There's a question back there, yeah.
What's the depth on the temple that you said you were going? When you said the spot on the temple, what's the depth?
This way over here?
Yeah.
You drill it in. When you see the hair pushing out on the opposite side, you're deep. You got to feel bone there too. And the interesting thing is, as you start to inject, and we're going to do some temples. I think there was somebody asked, would I do their temples today? Are you still out there or did you run away? Oh, you have the list. Great. So we'll do temples. It's not the only way. Look, Steve Fagan.
It's the only way.
Steve Fagan's a great, great friend of mine, and he does it by doing a 5-to-1 reconstitution of his stuff. He'll use Ultra or he'll use Restylane, and then he'll use a cannula and he'll coat the whole area. But he ends up using a lot of product. The patients look all flooded. They have to massage. And he looked at me when we were together recently. He says, I'm changing to the technique that the one up, one over technique.
Yeah.
He said, because it just makes so much more sense. What you can get when you do that, and maybe we'll see that on the patient that we're going to do, is you can get a little bit of venous dilatation, a little venous engorgement, because the product is coming up from beneath and putting pressure on the vein. And so there might be a little engorgement, but it goes away after a day or two.
That doesn't matter.
Yeah, and they wear their hair down to cover it if they have hair, but,
When you're injecting, will you describe what products you use in that area?
Sure. As we go through, I'll talk about any product, whether you like it, whether it's Mertz, Galderma, whether it's Teoziel, whether it's Allergan. I told you, I'm an equal opportunity guy. For sure. Okay. I'll cover it as we go. Should we get to that?
Yeah, let's just do it.
Let's get a patient up, and we'll still answer questions as we're getting the patient ready.
Let's do one last question, and then we'll get going.
Okay, then pick anybody from the list, and we'll start.
All right, sounds good.
Sounds good?
Just is there use for nitroglycerin under the tongue and your experience with 5-FU and the Mesamix?
Jessica?
Any use for nitroglycerin under your tongue or the patient's tongue? The patient's tongue. When they have a vascular accident, I don't think so. It's going to give them one big hell of a headache, but I don't think it's that definitely is more of a systemic effect. And then what you worry about is stealing blood away from the areas that are blocked, because everything's going to dilate, but the block will still be there and it'll steal whatever little blood's getting through. Nitro paste is the way that we do it when we have flaps that are in trouble. But when we have a flap that's in trouble, what we're trying to do is open up the peripheral circulation. You can use nitro paste on day 1 or day 2 after you've treated somebody with hyaluronidase. That I'm okay with because you're opening up all the circulation in the area with the nitro paste, but not as an initial treatment, please. Okay?
And they actually haven't had nitro paste since 1970. So it's not paste, it's a cream.
Spray. Or spray or
it's
cream.
Cream
Yeah.
or
cream.
spray, and it's traditionally is 0.2%. Have in your clinic 0.1. 0.1 is sufficient because 0.2 gives, as Arthur indicated, headaches, really.
Major headache.
So just keep the point. Just have it compounded. It's easy to compound. It's cheap and it's stable for at least 6 months.